Hi, my name is Vincent Curie. I'm the HIV vaccines product development team lead at IAVI. Science alone is not enough. When you look at the gains that have been made in the response to HIV, these have been made possible by commitments from governments, funding agencies, healthcare professionals, communities, scientists, all coming together to work towards the same goal. When thinking about HIV vaccine development, we do need sustained investment to maintain resources necessary for the research to take place, continued involvement by policymakers and governments in driving the field forward, and also involvement of communities. For everyone who's watching, I would say we are in sight of a vaccine that could effectively help us end the HIV pandemic within our lifetime.
All right, so by Judy, we'll see you a little later. I get to be by my lonesome now. I am thrilled to welcome all of you to, I believe this is hour 10 of our live stream. My name All right, so my name is Josh Barocas. Thank you for joining us on hour 10 of live stream Save AIDS Research. I am here in Denver, Colorado, where it is currently 6 o'clock in the evening. Thank you all for sticking with us, for joining us today, for any amount of it. This has been just absolutely wonderful, and we'll keep it going. So I'm absolutely thrilled to welcome our first guest of this hour, our first speaker, Alison Buttenheim. There we are. And Judy is still here.
Won't let her go. There we go.
We can't get rid of her. Alison, I will let you take it away. I know that you're out on the East Coast, so please get us going.
Great. And will my slides magically appear at some point? There they are. All right, thank you, Josh. I'm Alison Buttenheim at the University of Pennsylvania, and I'm really honored to have an invitation to join this incredible event. I've been tuning in all day and plan to tune in much of the night. And I'm delighted to share the PROTECT study, which is a study exploring how inoculation-based messaging can protect against HIV vaccine misinformation. A nice follow-up to the video we just saw about HIV vaccine development. This is an NIH-funded R01, and I'm joined by my other MPIs, Brendan Mon-Brown at the University of Cape Town and Harsha Tiramurthy at the University of Pennsylvania. So I was just teed up. That video was great in telling us that we hope the HIV vaccine is coming. We think of it as an epidemic-ending technology, and we think it will benefit many, many, many populations affected by HIV, maybe most adolescent girls and young women. This is Tembi Dlamini. Tembi was profiled in a 2016 Washington Post story about participation in HIV vaccine trials. Her older sister had died of AIDS, and at the time, Tembi said about half of her friends were HIV positive. And when we think about a vaccine coming, it's people like Tembi that we think will very much benefit. However, we know that this is also a group that's very vulnerable to misinformation. The kinds of things that people like Tembi might hear about an HIV vaccine when it's on the way or here are things like, it gives you HIV, or you only need it if your boyfriend fools around with other women, or the HIV vaccine makes it so you can't have babies. And with the speed of social media and the importance of social networks to adolescent girls and young women, we think this is a particularly tough hurdle or barrier to sustained HIV vaccine demand. So the PROTECT study sort of takes that as a starting point. So we hope to have this epidemic-ending vaccine in sight. We know adolescent girls and young women really stand to benefit from it, especially in places like South Africa, given the transmission dynamics. We do worry that uptake will be vulnerable to misinformation, and that compels us to look for novel communication strategies to inoculate individuals against pathogenic misinformation. So for the PROTECT study, looks at psychological inoculation, also known as pre-bunking approaches to building resistance to misinformation. This works just like an information vaccine. So the idea is that exposure to a weakened form of the misinformation can actually build antibodies, build resistance to the stronger forms of the pathogen, the misinformation that you might encounter in the wild. And the messages are structured a pretty specific way. So I just want to walk you through that. So if you're not familiar with inoculation, you know how it works. So it starts with a warning that misinformation may be coming your way. We try to invoke motivational threat. So something like, you might hear some things about the HIV vaccine, people might try to mislead you. And that's a strategy to really engage people's attention and focus so that they pay attention to what's coming next, which is what we call preemptive refutation. So either through fact-based refutation, logic-based, or source-based, we tell you exactly what's wrong with the misinformation. Either this is incorrect, here's what's correct, or this is the strategy or the tactic people are trying to use against you, or this source tends to not be credible or trustworthy or tends to be trying to purposely mislead you. So it explains the misinformation, and then often is followed with a call to action. So again, keep the vaccine analogy in mind. We are trying to inoculate you against that pathogen and build resistance. I just want to note that psychological inoculation is not uncontroversial across the public health and health promotion and vaccine and HIV prevention space. There's a lot of concern about giving oxygen to the misinformation. A lot of studies have looked at this illusory truth effect, where just the repetition of the misinformation can make it sticky and make it actually more credible. And because of that nuance and because of the real equipoise around the effectiveness of inoculation, we really wanted to study it empirically in a population and for a vaccine and for a set of misinformation where we thought it could be really important. So how did we build these inoculation messages? So first, we collect misinformation claims from the literature, from the gray literature, from social media. In our case, literature about HIV vaccine trial participation was really key. We want to then find out which of those claims are most concerning. And by that, we mean might most affect demand for the vaccine, but also are conducive to inoculation. So we might be able to sort of fit them or engineer them into that inoculation framework. And then we want to, in a very participatory way, I heard Laurent talk about sort of the innovation that we get from partnering with community. That's very relevant here for creating engaging, behaviorally optimized messages, whatever sort of mode or format or structure that is, to deliver the inoculation message. So in our case, we scraped a lot of literature, found about 300 claims. They grouped very nicely into these 7 themes that are not super surprising to folks on this call in terms of the kinds of things that came up, from safety concerns to licensing risky behavior. We had about 200 adolescent girls and young women in South Africa who participate in the prolific academic online panel, rate about 54 distinct claims from that set for concerningness. And the ones that popped up, again, were like, it'll kill you, or cause organ failure, or cause cancer, concerns about safety to children, so autism or disabilities or developmental problems caused by the HIV vaccine. We then had to pair those with the misinformation tactic that best fit it. We used the FLIC framework, one of several really helpful organizing principles to sort of think through the kinds of tactics and strategies, because we wanted to do logic-based inoculation that might be embedded in those claims. We picked 2. One was sort of a post hoc, Proctor hoc claim, something we heard a ton with the COVID vaccine, right? That like someone got the vaccine and then they died and it was because of the vaccine. So we had one about my sister got the vaccine and her heart stopped the next day. Don't get vaccinated, it'll kill you. The second one was around impossible expectations, which is something we hear also a lot with vaccines, right? That, yeah, sure, I'll take that vaccine as soon as you tell me it's 0 risk. So not a standard we hold any medical technology or pharmaceutical to, but one we hear as a reason for not taking a vaccine. I'll take it as soon as they tell me there's no risk of side effects or harms. And finally, we had to, again, bake those into actually messages that we could deliver in an intervention. We partner with an incredible organization in South Africa called Shout It Now, and harnessed the expertise and the insights of their peer ambassadors and peer navigators, a group of young women who work with the Shout It Now clients on reproductive and sexual health every day. We brought them in, we showed them the scripts we had developed, we showed them a couple of formats, an animation, an avatar, and we were told in no uncertain terms that our draft messages were way too Harvard, which we really loved as some guidance. So we turned the tables and we said, okay, go off in the corners in pairs. We'll give you about 20, 25 minutes. You create videos for us that are the look and feel of what we're looking for here. They can be about PrEP or about HIV prevention generally. And what we got were great. I wish we could play these for you. We got sort of TikTok style dance videos. We got sort of two friends talking to each other. And then we got sort of friendly talking heads talking at the camera. And those were extraordinarily helpful in helping with our media company. We worked with a video production company to bake these into 2.5 minute, again, TikTok style videos, each one of which walked through the inoculation steps for our 2 misinformation claims. Also wish I could play these for you. They are awesome. They are in the style of the same actor playing 2 different characters, sort of cutting back and forth, one more clueful, one a lot more clueless. So where we are now, we have a pilot trial of about 1,600, again, prolific academic participants underway. We are actually almost done with that trial. Again, based in South Africa with adolescent girls and young women. And our outcomes in that trial are just like a vaccine trial. So safety, efficacy, durability, and generalized immunity effects of those messages. And look forward to sharing results from that pilot with you soon. Next step is an in-person trial with Shout It Now participants, so clients coming to their mobile PrEP and sexual and reproductive health services vans. Will also be about 1,600 people. We love the sort of flexibility and efficiency and speed of doing these trials online. We also think there are enormous benefits to running the trials face-to-face, where we can see the participants interact with the video content, and also recruit a more diverse panel than we're able to on prolific academic, which is actually a pretty highly educated, high SES participant group. Unfortunately, as of last week, this NIH grant is being terminated, and I'm going to try not to tear up about that. Shout It Now has also undergone big cuts due to PEPFAR and USAID funding cuts, and not offering the services where we were going to host the trial. So the future of the PROTECT study in terms of this approach and this trial is pretty uncertain. We are hoping to pivot, maybe with some new funding and a slightly different approach, to apply this to lenacapavir, which I think hopefully is sort of an obvious next step for folks on the call to think through. We might think about the same misinformation claims, the same vectors that we were anticipating with the HIV vaccine. And of course, len is here, or coming very, very soon. So we're already seeing some tweets sort of claiming that, len will cost $45,000, which of course it does now, but hopefully won't when it's rolled out in LMICs, or that it is a vaccine. I think there's already sort of confusion about what kind of technology len is. We have an amazing group in South Africa. We have an HIV nudge unit called Indlela. They have a behavioral lab and a behavioral hub where we can very rapidly do this sort of prototyping. And what we really hope to do is create sort of an engine to demonstrate the effectiveness, hopefully, of these inoculation messages, but also the speed, the implementability, the scalability, and sustainability of this kind of messaging, because the misinformation comes fast and furious, and we need to be able to hear it, do the social listening, translate that into messages, and have those as very easily scalable and implementable messaging for our partners. So that is where we are. I cannot say more amazing things about the PROTECT team. It really is the most incredible team I've ever worked with. Wonderful science. I hope we get to continue it in some form, and very much look forward to discussions and questions. Let me stop there.
Alison, this is, I wrote down 1,000 questions.
Awesome.
Just so you know, you're seeing in the chat fantastic, fantastic work. And you actually took my question away around Len. And for anybody that's on here, lenacapavir is a long-acting medication that is able to be used for HIV prevention. And one of the things I was going to ask, especially with the last panel, where this is one of those places that HIV, what started in HIV research, may transform how we do work elsewhere. I'm curious, where else can we apply this sort of similar framework beyond the HIV community?
Yeah, and by that you mean the inoculation framework?
The inoculation, this is so fascinating, and it could, to me, it seems like it could be anything, anywhere.
Yeah, so it's been around for a couple of decades, and it really emerged in the climate space and climate denial. In fact, that FLIC framework that I showed was developed to sort of think about pre-bunking or debunking climate denial myths. But I will say, even before the COVID pandemic, but certainly as we swung into the COVID vaccine rollout and the crazy misinformation ecology that we were all steeped in and continue to be steeped in, lots and lots of researchers reached for it as an opportunity. My colleague here at Penn Nursing, Melanie Kornitis, has a now terminated NIH study looking at inoculation for the HPV vaccine, which I think is enormously helpful. What you want with inoculation is to get out ahead of people's about the attitudes and behaviors that are sort of in formation. So if someone's already decided about something, pre-bunking isn't going to work so well. If they're still deciding, or they're just starting to hear about it, or some voices are louder than others, that's the moment where it's really effective. So that's why we thought an emerging vaccine, and now Len, an emerging technology, or something like HPV, where a parent or caregiver might not think about it until the kid is reaching 9 or 10 or 11 years old, works well there.
It also seems like this can be applied in small settings, within a hospital setting, within a clinic setting, or across an entire community. And perhaps, and I'm curious, this seems like it's targeted currently around health and patients. Is there any work right now around targeting this toward policymakers? And actually, because we as researchers, as scientists, we're oftentimes some of the first to know about something that's published in a big journal, and we could actually get out ahead. Has this framework been applied in the policy making setting?
Yeah, it's such a great question, Josh. I am really interested generally in how these sort of behavioral science principles, cognitive psychology, social psychology, including inoculation, can be used with policymakers, because they are subject to all the same and vulnerable to all the same sort of decision-making characteristics, persuasive strategies that lobbyists or bad actors bring to them, and building their skills in sort of information literacy and evidence literacy through something like inoculation, I think could be really, really effective.
Yeah, absolutely. And not just, and I want to be clear, it's not just policymakers, right? It's civic leaders, it's community leaders. We need to pre-bunk. I really like this term. We need to pre-bunk on a host of health issues. I think about, the way that we have unfortunately watched some of the policies and practices unfold, not just within HIV, but within the opioid epidemic and the overdose epidemic. This is an opportunity where there's an established framework that can be applied from the, at this point, HIV world. I know that it came around before, but into something bigger.
100%.
Your research is just fascinating. I am heartbroken with you. I'm holding in my tears because it'd be bad if both of us start crying on screen, and I'm holding in my tears. But Alison, it's a pleasure, absolutely, to hear your work, and thank you, and know that you have a community of people around the world supporting you. So Thank you.
Thank you, and stick around for Jennifer coming next. We are longtime buddies in the vaccine wars, and she's fantastic.
You set me up perfectly. We have a quick video, and then we have Jennifer Reich.
I'm Reverend Rob Newells-Newton. My journey as an advocate and educator in the fight against HIV began back in 1999. In 2005, my personal mission became even clearer when I tested positive. Then in 2012, the first pill for HIV prevention was approved. I've been a research advocate since then, fighting for as many new options for HIV prevention as possible, especially options that fit into people's real lives. We've come so far, moving from complicated daily pill regimens to new long-acting options. This isn't just about medicine. It's about giving people choices that work for them. But as long as stigma and criminalization around HIV and LGBTQ identities exist, our work isn't done. We still need a cure. We still need a vaccine. Sustained funding for HIV research isn't just about science. It's about justice. It's how we'll end this epidemic once and for all.
Really hard to follow those words. I would love nothing more than to call up Jennifer Reich, who's a professor of sociology here in Colorado at the University of Colorado. And I will pass it over to you. I think that I can't see your building right now, but I might be able to, if I step out onto Colfax, I might be able to.
We are neighbors.
Yeah, I'll pass it over to you.
Thanks. And thank you so much for inviting me. Thanks to Judy for thinking of me in this topic. I feel really honored to be part of this day, to take the baton for the next 20 minutes or 15 and talk to you about the things I think about. So I've been studying vaccine decision-making for, going on 20 years. Alison is correct that we started early on together in our careers, really thinking about what this means. And every time I think we're slowing down on the conversations of vaccine hesitancy, I find a new wrinkle. And I wanted to really bring into conversation where we are at a federal level thinking through these issues by really talking about the Make America Healthy Again initiative coming from the White House and Department of Health and Human Services. So just to start us off, I think it's worth acknowledging that for a long time, we've all lived with what sociologists have called the vaccine narrative, this idea that vaccines are always safe and always necessary, and that there's been popular support for it. We could think of the campaign for the polio vaccine, the research that was funded by the citizens, by the people with dimes dropped into movie theater buckets that formed the March of Dimes, literally, and the ways there was broad support for a solution to a disease that was paralytic and 1% to 2% of people infected, about the same rate of serious complications of COVID, actually. And to think about that vocabulary, that we all accepted that, and how powerful that was for a long time. That starts to shift in the 1980s. And we see the first signs of sort of cracks in the vaccine narrative in terms of families that are now talking to each other about their perceived harms done to their children from the whole cell pertussis vaccine. And I will acknowledge there is robust arguments in the about whether this was correlation or causation. I've also interviewed a lot of attorneys and representatives in the vaccine injury compensation program who do say when we move towards an attenuated vaccine, those claims went away. But nonetheless, those kinds of conversations of parents' lived experiences really started pushing back on this expertise that vaccines should be absolutely trusted as recommended without consideration. And it's worth acknowledging that a lot of those questions in the 1980s really emerged from AIDS activism that was happening at the same time. It emerged from the women's health movement. It emerged from the disability rights movement. It really emerged in a lot of ways by borrowing vocabulary from a range of movements that ask people with lived experiences to be taken seriously within science and within research, and to demand that their voices and experiences be treated as valuable and valued. And so it's always interesting for me to really think about the decision to reject vaccines within this broader context of what does it mean to feel like an expert on your own health and your own body and your own well-being, because I think there's lots of ways we can complicate that when I have more time to talk to you about it. But they're questions I think about all the time. So just to remind us all, right, the reason we approach vaccines from a herd immunity standpoint is that we know we can never achieve 100% immunity in a community. We know that there will always be people who cannot be immunized because they're too young, they've lost immune memory with age, or they're immune compromised. And so looking at this really crude drawing, if we think about the people colored red as infected with a vaccine preventable disease, And we think of the people who are blue as unimmunized for a range of reasons, including religious belief or personal choice, but also underlying medical condition. We all rely on that critical mass of green people to support community immunity that creates essentially buffers between those who are infected and those who are vulnerable. And that herd immunity level is really important to us. When we think about it, I think in public health, we often talk about it like it's all one thing, like herd immunity is one thing. And we sometimes forget the nuance that it actually varies dramatically by diseases. And so because we're living through a surprising sustained measles outbreak in the US right now, I thought I would start with measles and to really highlight as an example that we know that the R0 factor, the reproduction factor of one case of measles, is roughly to 12 to 18 new cases. And because it's so contagious, considered one of the most contagious viruses, we need a really high level of herd immunity to really support that kind of critical mass of those green people building that firewall. That rate might be lower if it's a much closer rate of infection, that it requires much closer contact for infection. But thinking about those herd immunity levels might vary at threshold, but we know we need at the baseline a critical portion of the population to be vaccinated or immune to protect people who cannot be. So what I think about in my work then is how is it people who want healthy children, who think hard about the decision of healthcare, come to decide not to immunize their children, or at least not to follow the recommendations as laid out by federal advisory bodies. So I'll say that I really focus on what kind of cultural threads draw to the conclusion that vaccines are not entirely necessary. And one of the most powerful ones has been one that's actually promoted often by medical providers and researchers and public health experts, which is this idea of individual responsibility for health. And we can see this language of individualism running through our apps, our family chats, our ability to use our trackers and to find out exactly how we're doing, to track our macros now, websites, marketing, consumerism, right? All points to this vocabulary that you are personally responsible for the outcomes of your health. And drawing on some of the earlier speakers, thinking about stigma and the powers that that has, what we know then is that leads to the conclusion that illness must be a personal failure. Somebody must have failed to work hard enough to avoid illness and thus is experiencing disease. And we just know it's scientifically untrue, that some amount of illness is environment and genetics and bad luck and is not personally amelioratable or controllable, but that falls out of the cracks within this broader cultural conversation. Simultaneously, we tell parents all the time that to be a good parent is to make good consumer decisions. And that could be on food, that could be on car seats, that could be choosing schools or opportunities, but that what counts as being a good parent is worrying about the success of your own children, but not necessarily all of the children in a community. And school choice is the greatest example of that for communities that have it, because it starts with the premise that some children can have failing schools as long as you can choice out of them and your kids don't have to. So it starts with a tolerance that not everyone can have the things that they need to be safe and healthy, but that choice would make it possible to avoid that. And we know that all of this then is powerfully mediated by class and resources. When I think of these things together then, what I see over and over again is that parents see themselves as experts on their own children. And unsurprisingly, they're drawing on a range of parenting advice books dating back to the 1970s that tell new mothers, for example, to trust their own instincts, to trust their judgment, that they know their child better than anyone, to not take no for an answer if they know the right answer. And so in many ways, the logical answer is to be hesitant about vaccines and to treat each vaccine as a consumer decision that you alone get to decide about. What that means then is I find parents weigh the risks of a disease against the risk of a vaccine as they perceive it. And the perception point is really important. So they consider how safe do they imagine the vaccine to be? What's the likelihood of infection? So they may say polio is really serious, but it hasn't been seen in North America since 1979. Chickenpox I had as a child doesn't seem very serious. But thinking about that how they understand this. They also think about each child in their family separately. And I was surprised to have a critical number of families in my studies tell me that they have different vaccine schedules for each child in their family because they see each child as an individual with different needs and benefits and risks and vulnerabilities. And those are really important as they weighed information. And at core, these are not anti-science positions, but they're positions that take that question of individualism really seriously. So at the bottom line, what I find over and over again is that vaccines have become a personal choice for personal benefit, that illness represents some kind of personal failure, and that all of that vocabulary, that you should use vaccines if you personally want them for your own protection, ignores, again, that question that We live in communities with people who are vulnerable, who often have HIV and AIDS, but also a range of other medical conditions and treatments that cannot be safely immunized, who need that collective protection. The challenge right now, as we're seeing it, is that all of that vocabulary of individualism matches, mirrors, and draws on the vocabulary of the MAHA movement. And it's not even, I don't even know if it's a movement, if it's actually institutionalized now within the federal government. But MAHA and the new MAHA report identifies, for example, that 40% of American children have a chronic illness, and that those are caused by only 4 things: poor diet, environmental chemicals, lack of physical activity or stress, or over-medicalization. And they have very specific targets for what they think should happen with antidepressants, anti-anxiety medications, and stimulants to control ADHD. And that those are the targets. So it doubles down on this individualism as a cause of illness. The goals then, and it's worth thinking about what these mean, focus highly on an individual level of individual level of intersection, interaction, and intervention. So we could think about what does it mean then to support individual choices, whether it's uniform use of trackers, which is one of the proposals, without the requisite data privacy we would all expect, down to these kinds of corporate partnerships that allow for individual choices. And none of that gets at the core basis of what we think of as social determinants of health, and how inequality structures opportunities to make these choices, even if these choices were entirely predictive of health outcomes. So when I look across the blogospheres of who's excited, what shows up frequently is that there is grassroots organizations who have been longtime opponents of vaccine mandates, who see a huge amount of support right now coming from the federal government in terms of thinking about eliminating vaccine mandates, but also thinking about junk food, food processing, and things that honestly many public health experts have been arguing for a long time. And so thinking about what this means then as we move forward on the front of vaccines is really important. So as a reminder, we have to always remember that we have a critical mass of any population that cannot be safely immunized that we have to think critically about. And within that, we also know that there are some people who will choose vaccines who will never seroconvert. Vaccines will not work for them, and they're at risk. Coming back to measles then, what we find is that we are living through this moment where we are seeing high measles rates and the continual spread. As a reminder, measles was considered eradicated in 2000. So the fact that we have almost 1,500 cases in the US right now, and that's growing, is important to think about. We also know that there's roughly, I think, a 12% hospitalization rate right now for those infections. And we've seen 3 measles deaths this year so far, the first since 2003. So the stakes of what this means for all of us are significant. What we also know is if we look nationally, every state that's colored in any orange tinge is below the threshold we would expect to see for immunization rates to protect against measles at a community level. So what we know is we are below herd immunity levels for measles, and that raises questions for what that means for the folks among us who might be the most vulnerable. So thinking about who those are, and for the purposes of, I think, our work in this call, I think it's worth highlighting what does it mean to encounter something like measles with HIV or AIDS. And there's some interesting and historic work, and there's some more recent work. And there was a recent study that suggested that in their clinic setting, they found that that only about 18.2% of the 13,000 people they studied had presumptive measles immunity, and about 18% tested as seronegative, even if they'd been vaccinated. And so to think about what that means, in addition to infections are likely to cause worse outcomes with a compromised immune system, we know that no matter how hard someone works, they will not be able to control the worst outcomes of infection. And you can't even control the opportunities to be infected for something like measles, which can stay in the room for more than 2 hours after an infected person has left. So even if we imagine you had the power to make informed decisions to avoid measles, we know it's biologically impossible, and that's worth putting front and center. Now, I guess a little good news is in order, which is to say that the majority of Americans actually want mandates for schools. And that's true across the country, including in Florida right now, which is considering how to get rid of their mandates. So we know that when asked this recent study last week, 2 weeks ago, do you want the federal government to be involved with MMR vaccine policy? 70% of people polled said that they would like parents to be encouraged to vaccinate. We also know that despite the partisan divides that have emerged since COVID around vaccines, even a majority of people who identify as Republicans, which is the most vaccine critical group we measure right now, also want to see that encouragement. And that's really important for us to think about what are the expectations, even across partisan lines, that we agree on in terms of what we want the role of government to be in preventing infectious disease. Now, as we think about where this takes us, there's a few takeaways I'd like us to focus on. So one is that I think it's important to stop referring to people who reject vaccines as ignorant or anti-science or deluded in some way, but to really ask this question about how are they responding logically to the culture of individualism and health promotion that we've fed them, that we've put in front of them, and that we've encouraged them to think critically about. We also have to recognize that while this might have been considered a cultural norm that existed in the margins, it is now central to federal policy and federal leadership. And we have to grapple with what that means when federal resources and public health dollars now will be refocused on ways to influence personal choice or corporate behavior rather than public health interventions that work at the community level. And then as a last piece, I think the piece we never acknowledge most directly is that we frequently don't acknowledge that our own choices when we do choose to be vaccinated are part of us participating in a community strategy. So vaccine manufacturers have embraced a vocabulary of personal choice. We see public health departments suggesting people vaccinate for themselves or their babies. We see HPV vaccine campaigns focusing on one less or not being mad at your mother that you got cancer later. These individual level solutions have also fed this notion that it's an individual technology for personal benefit. And I think we would all be well served for having more honest conversations about the ways that those of us who can be safely immunized can be part of a community solution, and that we are part of protecting the people amongst us who are most vulnerable, and figuring out what it looks like to perhaps normalize those discussions. And I can stop there, but thank you so much for letting me be a part of this day.
Thank you. So just like Alison, I have about 1,000 questions. But in the chat, Godfrey had said something that actually I'll piggyback on. It says, thanks for this. It's more important now than ever. We can't afford to put everyone at risk just because people are not willing to accept facts and the effectiveness. And my sort of piggyback on that is, how do we mobilize, and you mentioned this at the end, how do we mobilize people right now to care about their neighbor, to care about that vulnerable kid that they may or may not know that they're seeing in the grocery store or that's across the street? What are the ways that we can do that?
Yeah, I think it's a great question. And I try to remind myself that during COVID, at a time of a declared pandemic, when everyone was terrified and we didn't have vaccines and we didn't have even clear answers of transmission, we saw people in every community doing generous things for each other. Yeah. We saw people buy groceries for each other. We saw people maintain services to small businesses, or buy gift cards at small businesses to help them survive, right? We saw people protect seniors in their neighborhood who couldn't get outside, right? We saw generosity. And I think we sometimes lose sight of that because we're so focused on talking about the polarization, which is real and problematic and important to think through. And we know that people are willing to be generous when it comes to the people that they know in their neighborhood. So maybe it's that child that they do know, or that family member who is immune compromised. They can think about that, but that's an okay place to start because that can build outwards. I think it's important that people who work in public health and the way we do research, that we really grapple with our contribution to individualizing all of health interventions and turning life-saving community strategies into consumer choices. Mm-hmm. And there's been a lot of ways that has been incentivized, whether it's personal health savings accounts or messaging, but we can really grapple with what does it mean to start to change that conversation? And we have other examples with things like diabetes interventions and other community solutions where we know that people are worried about their neighborhood and they actually step up for each other. And so I think we can actually think about how do we re-norm that conversation. We know also that when people are experiencing scarcity and that scarcity mindset, it's much harder to move them towards generosity. And so we can also think more fundamentally, what does it take to remove some of that fear and scarcity experience as people are struggling right now? I'll say I find it disingenuous to talk about herd immunity if we don't do anything for the herd, right? That we ask families to contribute to the community, but the community is not doing a lot for families right now. And that's also part of what we have to grapple with.
Sure. So it's sort of a double-edged sword isn't the right way of saying it, but that we normalize generosity, but also recognize that that we need to individualize generosity as well. And I think many of us truly struggle with the idea of patience and being generous or being accepting or being understanding in this polarized world. But it's a really good reminder that we have gotten, just because I know that the measles vaccine works, and I know as an infectious disease doctor that measles is terrible, it still takes a little bit of patience. This has been a discussion. Your presentation has just been a reminder that maybe I even need to take a deep breath sometimes. Jennifer, this is absolutely amazing. Thank you for taking the time, taking the baton for 20 minutes, and being with us.
Thanks for including me.
My pleasure. We're gonna cut to a video, and we'll be right back.
My name's Brian Minalga, and I work in HIV research. When I was a kid attending public school in the late 90s, the teacher of my health class taught us that AIDS was a disease created by gay men, and that all gay people would suffer a horrible death from AIDS. He smiled when he said it. I'm disgusted when I think back to the way this man used his position of power as a public school teacher to package his hateful extremist beliefs as facts and to put his students' health at risk. HIV research set me free. It taught me the objective truth about this virus. And HIV research, free from political influence, matters for everyone, because without the truth, we're not free to make our own choices. We're subject to the motives of others. Save HIV research so that the truth and our lives will.
Many of you may wonder why I take a second in between after a video. It's not because I don't know what to do. It takes me a second not to start choking up and crying when I hear these videos and watch them. So for the last 20 minutes of this hour, number 10, we're going to bring on Lisa Hightow-Weidman and Sybil Hosek, who are going to talk to us about investing in youth, investing in impact. And Lisa, I just have to say, personally, you have been a research hero of mine since as long as I can remember. So just actually being on the same screen is a delight.
Well, that's not fair to make. That's not fair. Choke me up before. Luckily, Sybil's starting the presentation.
What do you mean? I feel the same way. I feel the same way every day.
Man. You know, my son is actually in the background here in my hotel room, so that actually, he might actually think I'm kind of cool after that.
You're pretty cool.
Thank you. We are honored to be here, and we're so honored to have been asked to speak. So Sybil's going to start. I don't see the presentation. Is it up yet? Or okay, fabulous. You guys are so good. I just had to say.
This is very cool.
So Sybil's going to start, and sometimes they call us Libel because we are kind of interchangeable, but she's going to give us a start. So.
Yeah, thanks so much for having us. So yeah, it's like happy hour. You get 2 for the price of 1 today. That's how we like to think of ourselves. So like Lisa said, there was a talk earlier today about the HIV networks, and those were more of the international networks. But we're going to talk a little bit today about, or I'm going to talk a little bit about why we need an adolescent-specific network here in the United States to address HIV, and then Lisa's going to go into more of the details about the ATN. So I'm going to hopefully go pretty fast. If I talk more than 5 minutes, she's going to just cut me off, which she does all the time anyway, so that's okay. So, a significant proportion of young people in high school are sexually active, and as you might expect, that increases with age. Almost half of young people who are graduating from high school have had sexual intercourse. Yet, next slide, we are seeing HIV testing rates that are plummeting. This is over the last 10 years, we are at an all-time low of about 10% of these youth hitting the community never having been tested. And I think this is always my kind of call to action for providers, pediatricians, adolescent medicine, family medicine, anybody that's seeing a young person. The CDC recommends that people over the age of 13 get tested for HIV. And we do not have a way forward to ending the HIV epidemic unless everybody knows their status. So we've talked, I think, a lot today, and I just please shout out to the people who have been on here for the last 8 hours. I mean, you're all just amazing. And so thank you so much for hanging in there with us. But we've talked a lot about inequities, and those inequities exist in the US with HIV diagnoses as well. There are racial and ethnic inequalities, there are geographic inequalities, and certainly inequalities by age. And those same inequalities translate to PrEP use as well, to PrEP need as well as PrEP uptake, with young people being the least likely group to be actively engaged in a prevention method. We also see among adolescents and young adults, so 15 to 24, that really the highest proportion of sexually transmitted infections other than HIV is in this age group as well. The statistic there shows that even though youth are only 23, or about a quarter of the sexually active population, they actually make up about half of new STI diagnoses, particularly chlamydia and gonorrhea. And, you know, when it comes to syphilis, Connie spoke earlier today about this massive increase in syphilis that we're seeing, and that's also impacting young women and other people of childbearing potential and the rates of congenital syphilis. This just gives a little example of kind of in the new diagnoses for adolescents and young adults, which we see really are not decreasing the way that we would want them to, and kind of the breakdown of sexual activity among those who are living with HIV or have been diagnosed with HIV. And then when we're talking about those that are living with HIV, again, unfortunately, age plays a big role. In the HIV care cascade, from testing to getting some care to being retained and viral suppression, adolescents and young adults are always in the lowest tier for those who are virally suppressed or engaged in care. Yet we find that young people are more likely to engage in sexual activity that puts them at risk for HIV, or if they're living with HIV, because they're less likely to be adherent and unsuppressed, more likely to be able to transmit to other folks as well. So that brings us to the ATN, and I'm going to just briefly go over this slide. I know it's a dense slide, and there were some comments about slides earlier on today, but you know, really what we want you to know is the Adolescent Trials Network has been around for over 20 years, and it was developed to address these very issues of young people in the United States. It springs out of the Pediatric AIDS Clinical Trial Group. And we actually heard from Sharon Nachman, who's really stayed with Impact and the PEDS agenda earlier today, but we're focusing on youth age 12 to 24 in the United States. We are the only network, the HIV Research Network, exclusively focused on ending the HIV epidemic among adolescents in the US. We have had over 150 studies over those 20 years, more than 30,000 enrollments, and really have worked tirelessly to collaborate whenever possible, both with other HIV research networks as well as implementers and implementation groups such as the CDC such as the CDC. And then, one of the highlights, just to say a highlight of kind of the history of the ATN, we were responsible for the research that led to the FDA label for HIV PrEP in adolescents, which happened 6 years after the approval for adults. And we've worked, again, tirelessly since then to close that gap and to make sure that adolescents have access to same products as adults do. at the same time that adults do. So we've made a lot of progress. Again, we've been engaged for over 20 years with this population, but there's still a lot of gaps. And that's why we, and Lisa and I came together for ATN5, which I'm going to pitch over to her.
All right. So you've met us. You've heard our. We didn't pay Josh, but I might send him a bottle of wine or something to thank him. But so Sybil and I, we've known each other for years and years. We've both been involved in the ATN since 2006. So we grew up in the ATN. We found a home in the ATN, and we love the ATN. It's a family. We have different expertise and backgrounds, but we came together to launch this new ATN and to get that award, and that is us. The structure of the ATN, and I show you this just to show kind of the idea that we think of ourselves as kind of interlocking cogs in a machine. And there's a lot of people and parts of the ATN, but youth are centered within our mission, which we'll talk about. We work collaboratively with NIH. Our colleagues at NICHD, who are the main funders, are truly exceptional. I'll shout it out in case they're on the call. But they are as much invested in this work as we are. And the collaborative nature of this, which sort of drives this network to really focus on ending the HIV epidemic among youth. And as I said, youth are the center of the ATN. And so we have multiple avenues for which youth are engaged and part of it. There's two kind of arms. One of these, what we call the subject matter research consultants, and these, we call them the SMRC. And these are young people who work, I work at Florida State, and they are hired to work with us on across the ATN and other projects. But they're young people who reflect the target demographic, and they're hired in a capacity that they can actually engage in a way that isn't sort of an advisory board capacity. They can truly be engaged from conception through dissemination. And they've really worked throughout on all of our studies, on all of our recruitment materials, on all of our study surveys, et cetera. And then we have another group that makes up our National Community Advisory Board. And these are young people that come from the sites, the ATN sites. And so they can really advise on what's happening at the ground level at the sites that they're working with and translate that information back to the young people at the community level. So just briefly, these are our current research projects within the ATN. And as Sybil said, our focus is to end the epidemic. And to do that, we really have to tackle really all aspects of the HIV prevention and continuum. And within our ATN currently, I think we do that. So ATN 164, which is our Screen to Prevent study, is a study about incorporating diagnostic screening for HIV testing and PrEP awareness into emergency departments using EPIC or their electronic medical record. ATN 165, this is our LIPS study, linking youth to PrEP services. I like to call this kind of the pizza and PrEP or Uber PrEP, where we're actually thinking about how can we take PrEP out of the clinic and deliver PrEP to young people where they might want to acquire it. So either mobile vans, community venues, or really any place they want to get it. ATN 166 is our CHOOSE study. And this is looking at different options. So we know we've heard a lot about the different PrEP options in decision-making, but how can young people really know what PrEP is right for them? And so this is a composite of digital tools to help young people and their providers make decisions and then provide them with the right PrEP and perhaps the right PEP with doxycycline. 168, 172, this is our project, which is looking at a combination HIV and pregnancy prevention for young women. And this will, the first part was looking at what do young women want in a combination prevention product. And then the 172 part will look at actually, hopefully the first in human trial in adolescents of a multi-purpose combination prevention product. ATN-170 is impact. This is a study that is a virtual study that will be looking at stimulant use and depression, as well as HIV suppression and PrEP use. So it's a serostatus neutral intervention to address young people who are using stimulants and how that might impact their risk for HIV, either acquisition or transmission. And then our last study, ATN-173, which is our Foxy-Doxy study, is a study looking at doxycycline prophylaxis for prevention of STIs among adolescent and young women in the US. And again, as you know, this is not currently an approved treatment for prophylaxis for young women based on the studies done in Africa. So this would be a large, hopefully efficacy study that could impact guidelines and treatment for young women in the US. So a huge kind of breadth of studies that we're doing. We have sites really all over the U.S. Geographically. These are our current ATN studies. 12 sites across the U.S. That are involved in the ATN, including 2 virtual sites. So as the first presenter in this hour mentioned, we were also subject to that awful termination notice. It came on March 21st, approximately 1:17 p.m. If I'm remembering correctly, which sadly I think I am. And it was a termination notice as the ATN did not adhere to the current agency priorities, et cetera. You can see some of the wonderful news stories that I think helped us with our cause. What did we do? I think after we did our fair share of crying and little drinking, probably for me, we really tried to figure out what we could do to get the ATN back. We rapidly filed an appeal. We did any interview with the press that was willing to talk with us. We talked with additional Congress people. We talked with the Surgeon General's office, really anyone and everyone. We had a social media messaging. Again, we met with national politicians and political aides, and we had a strong community advocacy and institutional outreach. And these were our talking points. We were one of the, I think, the first appeals that I think hit the desk of NIH when it came in. And we really focused on the value of the ATN, which we really believe in, that the impact on the scientific community, collaborators, staff, and trainees, the impact on the economic and national competitiveness, but also the cost. But again, I think we also really tried to show how the ATN directly aligns with the Make America Healthy Again kind of idea, and that you can't make America healthy again if you leave youth behind. And so we really tried to, stress these messages in our talking points. We were happy that a couple months later we were reinstated. Our appeal was approved, and then just earlier last month, our Operations and Collaboration Center, which funds our sites, was also reinstated. But I think it's really important even after that to remember that we were reinstated with this advocacy, but the momentum and the trust that we have had over 20 plus years certainly have been harmed. Our infrastructure, which is the backbone of progress, really is what we need. And I think that we, really need to continue. And I so appreciate this 24 hours, but that this only with sustained investment are we going to be able to get to the solutions. And I'll just end by saying that, the ATN extends beyond HIV. Our agenda really has implications for all areas of sexual and reproductive health, substance use, mental health. I think we are a model for youth-centered science. We really have a huge swath of experts who understand young people, who want to work with and for young people to really address and create interventions that lead to practical, scalable, sustainable solutions. And for us, we really center adolescents and young adults in this work. And as such, we are exemplify what the NIH missions is and should be. And only with the ATN and this work will we find a future where HIV is no longer a threat. And I thank you.
And that is why you are one of my researchers.
I honestly, if we need to go, I don't know. Next time we have to figure out a time to get together and just hang out.
Sounds great. I would love that. We are at the end of the hour. There are some questions in the chat, but I will, maybe you both can answer offline. I absolutely believe that the ATN is, as you said, sort of the I don't want to say the pinnacle. It is the pinnacle of youth research, and we cannot make America healthy again if you leave youth behind, for a whole host of reasons. So thank you both for all the work that you do and for being you. So thank you.
Thank you, Josh. We appreciate it.
Thank you.
Thanks.
So I think we are about to start our 11.